You're listening to the Addiction Medicine Podcast, the official podcast of the Governor's Institute. If this is your first time listening, thanks for joining us. The Addiction Medicine Podcast is designed for healthcare professionals and others interested in addiction medicine and will feature thoughtful conversations and insights from clinicians, patients, and families, policymakers, and other stakeholders. Remember to make us a favorite wherever you get your podcasts. You can also stay connected with us at governorsinstitute.org or follow any of our social media channels at @govinst.
Good morning, everybody. Really excited to be here. I want to thank the organizing committee, Sarah, Jeremy, and the crew, and thanks for the invitation to speak. Looking over the two-day events, just some amazing presentations, amazing people working in the field. So it's really a privilege to be kicking off the conference. I'm going to do an overview of drug trends, which means I'm going to have some crossover with the forthcoming speakers who are going to kind of probably drill down a little bit more. Mary Beth Cox coming after me, talking about substance use trends. Kove Arami talking about urine drug screens and, maybe how we use urinalysis as sentinel surveillance. And then what I'm really excited for is Dr. Robin Jordan and Zoe McElligott. Zoe's working with Nabran Dasgupta at UNC in the Street Drug Analysis Lab and is really doing some amazing work trying to figure out the transition to xylazine. So I'm going to kind of introduce that and they'll drill down more on that. I like presenting the epi because it's really the background and trying to tell a story with the data and what's going on, because I think it helps clinicians. It helps people in the field knowing kind of what drugs folks are doing, how the supply is changing, what are the implications for individual health and also public health. I kind of just wanted to start, and I know I won't really do this, but I kind of just wanted to take a quick moment of silence, not only because my heart is beating really fast right now, but just because all the people we lost. There's so much death and sadness in the world right now, and especially amongst our people struggling with substance use disorders and addiction. We've lost so many people. I've lost dear friends, and we all know someone we've lost. And so I was going to take a quick moment, couple seconds, just to, think of the people we lost. And thanks. And so I'm going to show a lot of data, and most of this is unpublished. And sometimes you get in trouble with journals for presenting unpublished data before you publish it. But I really feel the need to present it. I feel like the epidemic is moving so quickly and changing so much, and people need data. And so most of this is unpublished. And I'm going to be using the cursor, so I'll be turning like this and probably messing up my voice just to show kind of the trends, to highlight things. So let me excuse that up front. Also disclosure statement. I got no conflict of interest, financial conflicts, with this work. All right. So I just want to kind of, go over, what we've been calling the waves of the epidemic and how the epidemic has changed over time. I like using the term waves because, we know that the opioid epidemic started iatrogenically with prescription opioids, right? And then it changed and morphed into heroin as the second wave and fentanyl as the third wave. And now we have a fourth wave, so to speak, with illicit stimulants. And just to kind of using mortality data has been the best measurement to do that. We've been collecting data very similarly for 30, 40 years. And so it's a good measurement of trends of the drugs people are using and the type of drugs that are causing harm in the community. And so if you see here, the prescription opioid line is really the biggest. This is the first wave and, started in 1996 with OxyContin. In 99 and 2000, we started to blip on the radar that deaths were increasing related to drug poisonings. And as you can see, the opioid crisis, that's really the big line up until the end of 2015 with 14,000 deaths. And these are mutually exclusive. You can have all these drugs on your tox report. And so that's the first wave. But if you look here, the second wave is heroin. And in 2010, really from 2008 to 2010, heroin supply started to increase precipitously. Really on the backs of the prescription opioid epidemic. Prescription opioid crisis produced millions of people who were dependent on opioids. And then we started to peel those opioids back in 2016 with the prescribing guidelines and just the awareness of all the diversion happening. And so we pulled that back, but heroin took its place. And that's really the second wave, starts in 2010 and really kind of takes off. Now, here's a big deal. I was at CDC at this time in 2016 when heroin surpassed prescription opioids in deaths. And we were like, holy cow, this thing is changing before our eyes. And took us really kind of by surprise. And so then in 2013, so that was the second wave. In 2013, we have the third wave here, and this is fentanyl. All this fentanyl is prescription fentanyl, the Duralgesic patches, the Sipsis sprays, the Buca tablets. But in 2013, illicitly manufactured fentanyl hits the market. There was a little bit of it in 2010 in Rhode Island, the Northeast, and stuff in the 70s is China white. But the fentanyl that we know today, illicitly manufactured, that's really 2013. And as you can see, the skyrocketing trend after that, and fentanyl surpassed both heroin and prescription opioids as that third wave. The fourth wave here is really cocaine and methamphetamine, seeing more and more stimulants in opioid overdose deaths. That's really important. In opioid overdose deaths, we're seeing an increase in people with co-occurring cocaine or methamphetamine, usually not both at the same time. And so these have been increasing as well. All right, this is from a study that in collaboration we're doing with the Drug Enforcement Administration. And, my work has really been focused on the drug supply. What is it about the supply that changes, and how does supply drive consumption? We often think of supply and demand in a kind of neoclassical economics way where demand really creates supply. You wouldn't make anything if you couldn't sell it, right? You'd have a factory of goods and you'd have overproduction, and it would just sit there with no liquidity and all your stuff in product. In the drug world, that doesn't happen. It's the opposite. Supply drives demand. You can want the best heroin in the world, pure and everything. You're not going to get it. You're going to get what's there. And so what people put in their drugs, you're going to do. You don't have a choice. You don't have a way to really test them. And so the supply really drives consumption as an effect of that. And so if supply drives consumption, it also drives consumption-related harm. And so the supply is really important to look at, but it's really hard to capture the drug supply, right? How do you do that? Where's the data out there at the state level, at the national level? Most of the data is with law enforcement. There's two kind of groups that engage drugs. It's law enforcement and it's people who use drugs. And then we got the sellers right there in the middle, but it's kind of quote unquote cops and robbers if you just want to throw it as a binary, right? And so where do we go? Drug users aren't collecting their data themselves. And so where do we get the data? Law enforcement. And so law enforcement data has really helped me kind of see the waves in the drugs, albeit retrospectively. But looking backwards, we can see these. And I'm going to make a case if we can look backwards, we can look forwards. So these are deaths here. And the deaths in this table here, the drugs are on the left side here. You can see the years, and these are the percentages. The only thing that's not percentages is at the top. And these are all opioid-involved fatal overdoses. So 25,000 and change to 50,000. You can see the doubling there. But if you break it down by specific drugs, heroin, 33 to 28%, so a little reduction. But if you take synthetic opioids away, which is basically fentanyl, in terms of drug mortality, the T codes, everything is listed under synthetic opioids. There's no fentanyl line. Now that synthetic opioids also includes Demerol, meperidine, tramadol, but it's so little that the synthetic opioid T40.4, I think it is, it's really all fentanyl. So if you look at heroin, barely went down, but if you take fentanyl away from the death certificate, look what happens. It goes from 32 down to 10, right? So deaths from heroin start plummeting over this time frame. Same for prescription opioids, look 45 to 23. But if you take fentanyl away, so they died with a prescription opioid in the system, but without fentanyl, look at 13 to 3, right? So prescription opioid deaths had plummeted. You could argue that's a big win in a way, right? Because that's what started the whole thing. And then you look at fentanyl, 12 to 73. That's the biggest jump right there, 73 for all deaths. In 2022, 108,000 deaths, fentanyl was involved in 83% of them. So we're talking fentanyl driving things. But if we're looking at the data, what does that show? Same for stimulants. Look, cocaine, 11 to 24. You could say, wow, that's a doubling of opioid overdose deaths that have cocaine. But if you take fentanyl out of the equation, it goes from 10 to 3. Right? So people dying from cocaine without fentanyl in the system, really lower percentage. Psychostimulants, which is basically methamphetamine. And the reason we do that is, again, the T40 point, I forget the name of the number of the code, but anyway, it includes prescriptions as well, right? So amphetamines, methylphenidate, Adderall. And so it's just psychostimulants altogether. But there's only like 4% are prescriptions, and they're mostly illicit methamphetamine. And if you look, there's a tripling of that, 5 to 17%. And that's the fourth wave that we're talking about. So continuing fentanyl, heroin deaths, opioid deaths, but with cocaine meth involved. And as you can see here, but if you take fentanyl away, we're talking 4 to 6. There's still a bump in meth deaths. This has been driving me crazy, this increase, because we don't usually see deaths associated with methamphetamine, and I'm going to get to that in a minute. Now, that's the mortality, and that's what we always use to look at mortality. And what I'm interested in is the supply. So how does the supply drive that, and how do we understand changes in supply? So back to law enforcement. Law enforcement data is really the only data, I would say, kind of systematically collected. So when law enforcement makes an arrest, they get that drug, they seize as an arrest, they test that drug. To go to court, you need to test the drug to prove it in court that it is the drug. And so there's a wealth of repository of data. Usually state crime labs, local crime labs keep that data. Some of those data they upload to a national system called the National Forensic Laboratory Information System, i.e. NIFLS. And NIFLS is the repository for basically state, local, jurisdictional crime labs. Here's the rub though. States aren't mandated to do it. They volunteer to do it. And they're all underfunded, as you can imagine. And so it's a system that's a little clunky. It's not a totally hermetically sealed drug seizure system, but it's really the best we have. And so how I use the seizures, and this is really important, I'm using the seizures as a proxy for the drug supply. So if heroin is seized, let's say there's 30% of heroin seized one year, and then let's say there's 30,000 seizures of heroin one year, and then the next year there's 70,000. I'm looking at that as an increase in the supply. Now, there are a lot of reasons why law enforcement does street rips or seizures, right? Could be political, could be economic. And so the reasons why law enforcement has an increase and decrease in seizures provides a limitation to this data, right? Because there's not a systemized approach where every arrest leads to this, right? It's uneven, but it's the best we have. And so I'm using changes in drugs seized as a proxy for changes in the market. And let me explain here. So this is the drug again, just like the same, and this is the years, and these are individual counts of seizures. And so all cases involving opioid stimulants and benzos, this is national seizures, 562,000 and change. In 2019, that went to 670,000. So all cases, there was an increase in the amount of drugs seized, and that could be for a variety of reasons, like I said. So when you take just all opioids, heroin, prescription, fentanyl, and DEA calls fentanyl, and fentanyl-related compounds because it includes precursor chemicals as well. 203,000 and change to 182. You could say, oh, that's a little drop in all the opioid seizures, right? But let's go by drug. Heroin, 127,000 and 214 down to 100,000. So a drop in seizures. Is that a drop in supply? There's a drop in deaths, right? Does that mean there's less and less heroin in the market, meaning less and less involvement in deaths? Prescription opioids, very similar, 77, I think it's 77,000 down to 42,000. So a reduction in opioids. Is that there's just less opioids on the street, less opioids being seized? Fentanyl, here's the big one, knocks you off your chair, 4,400 to 81,000. National drug seized. So for me, that's just not law enforcement increasing their street rips and seizures. That's an actual flooding of the market that law enforcement is encountering. Now, if you look at stimulants, very interesting too. 359 to 514. So an increase. Let's break it down. Cocaine, 161,000, 156. Cocaine supply hasn't been increasing. It's kind of been up and down and up and down. I'm going to show you an interesting slide about that. But cocaine has been pretty stable over time. Methamphetamine, not so much. 192,000 to 360,000, almost a doubling of methamphetamine. And this is just prescription stimulants and benzodiazepines. So on the one hand, we have this trend in supply, what I'm calling, and we have a trend in deaths. And my thing was like, hey, can we forecast? Can we use retrospectively the seizures and see if for every, let's say, fentanyl seizure that was seized, is there deaths related to that? Can we mathematically prove that? Meaning we can forecast overdose mortality retrospectively. Right? Going back. Law enforcement data is really slow. It's hard to use it for sentinel surveillance. It takes a long time for when a drug is seized to when it's tested to when it's uploaded in the system. And so it's really bad for sentinel surveillance, emerging threats. So it's in blood and urine tox, right? Remember, in the beginning of the fentanyl crisis, 2013, 14, 15, medical examiners didn't know what the heck they were getting. The DEA didn't even know what they were getting. All the STRIDE data, which is the quantitative testing, said unknown, this new heroin. So blood and urine tox is not really good surveillance. Just looking backwards, the same procedures. I'm going to close the talk today of talking about how we test drug and look prospectively instead based on the science done with this work. And so we compared both of them together. And these are just some graphs showing the trend that I just showed. So this is opioid overdose deaths, really stark line. This is the yellow line is drugs seized. And so this is prescription opioids. So as the opioid epidemic was raging, prescription opioid seizures went down, right? So sharp increase in overdoses, but really a reduction in the amount of opioids seized. All right, well, the next one I'm going to show is, there we go. That's the heroin one. Same thing, overdoses, heroin, right? Kind of discordant, right? It doesn't really look the same. If I'm right that the law enforcement seizures can serve as a proxy for supply. Now here's fentanyl. Now look at that. Almost driving. I mean, we're talking bumps here, bumps there, bumps here, bumps there. It's like when the increase in fentanyl is seized in an area, there seems to be deaths related to it. Now, so what we did here was we did a model using those two together. And this model is for all states and results. And my statistician, gave me notes to explain this. So I'm going to try to explain it really clear. This is all states and results for both case counts and percentages. And so we're using incident rate ratios, IRRs. And it's a really good metric to understand how if exposure to something affects the rate of something. So exposure to something, does that affect incidence? And what I wanted to look at here is, does exposure to drug C's have an effect on overdose deaths? And so what the 1.03 IRR translate to is that fentanyl and fentanyl-related compounds have the largest association with deaths. So for every one fentanyl case in law enforcement per 100,000, so every 1% 100,000 increase in seizures correlated with a 2.9% increase in opioid overdose deaths. And that's like, so every bump, every increase in one seizure was related to a 3% increase in deaths. Would make sense, right? Increase in supply related effects, i.e. here, mortality. So it also can be read as 1.5 increase in the opioid overdose rate per 100,000 people. There was a 1.5% increase for every point increase in exhibits. So there was an increase in death, increase in exhibits, but only for fentanyl. We didn't find anything for cocaine. We found nothing for prescription opioids, nor heroin, nor benzos. So none of the stimulants. And so we could say, did an increase in meth supply have an impact on opioid overdose deaths? What our data is telling us, no, it's really the fentanyl supply is the only thing that we found related. Now, that's a national study it's hopefully going to come out in the next few months. This was a state level study we did. And the slides I just showed you were based on this study. And this study was just in Ohio when we did the same exact thing. We had opioid overdose deaths and we had seizures. And what we showed here is the same thing. And if you look at this is heroin, fentanyl, and carfentanil. And that's the opioid overdose rate. This is carfentanil down here. Actually, a big bump in carfentanil. You see that bump there in deaths? That was related to carfentanil in Ohio. But what we showed is a very similar thing. Exhibits significantly associated. Every additional fentanyl exhibit was associated with a 0.5 increase in deaths. Now, what's interesting here is when you look at stimulants. So this is from Ohio as well. And this is stimulant exhibits. So law enforcement drug seizures. And this is methamphetamine here. So methamphetamine really took off in Ohio, just as it did both nationally. But we found no association with the increase in meth supply with an increase in opioid overdose deaths, meaning when the supply increased, there was no outcome on deaths. The only thing, and cocaine neither, the only thing that ticked it was fentanyl. And so what this shows us in grand terms is that fentanyl is really driving the crisis. So we talk about a methamphetamine crisis, and methamphetamine just generally doesn't kill people. It just doesn't. It's a slow metabolizing drug. You can talk to people who use it. They hardly ever see deaths. When you look at the mortality data, it's older people, over 60, 70 that die. And we could argue repeated use, heart issues related, but it's older population. Cocaine kills way more people, right? It has heart-related effects. And we know that it's deadly by itself, but meth doesn't. And that's why that 4.9 to 6% increase in meth deaths without fentanyl, I'm still trying to grasp that. But this just shows that fentanyl is driving stimulant deaths for the most part. If we took fentanyl away, I would argue that we wouldn't have a stimulant mortality crisis. And that's really important to understand. And so that is the 3 waves or the 4 waves, right? Prescription opioids, transitions to heroin. And we know with the transition comes different health effects, right? Heroin brings with it different health effects, different behaviors. So when the supply changes, consumption change, but also behavior changes. We saw an increase in hepatitis C amongst young people, 18 to 39, all over the country. But in Kentucky, North Carolina, Virginia, West Virginia, we saw that rise, but it wasn't until 2010, 2011. Right? Heroin increases. We start to see heroin-related issues, if you will, that were different than prescription opioids, similar to fentanyl. Fentanyl hits the scene. Now we're seeing way different things related to fentanyl. And fentanyl, people are using it, and it's changing their behavior, and it's influencing what other drugs they do. So the supply, my point here, has a really big impact on use and harm. And now we're in another transition. Right? I would like actually to go out on a limb and say we're actually experiencing a synthetic drug crisis. We're almost no longer in the opioid epidemic, which we are because opioids are driving all deaths for the most part. 85% of the deaths, cocaine and meth, relatively small, benzos, relatively small. And so that's a huge deal. And we have like 150 versions of fentanyl, right? Fentanyl analogs. The market is just insane right now, with all the stuff in it. And we're now in another wave. I don't know if it's a part of the fourth wave or a fifth wave, but it's a synthetic drug crisis. And we're starting to see designer, what I've been calling novel psychoactive substances in the market. Xylazine are the biggest, and Zoe and her crew are going to do a great presentation on that. I'm going to touch upon it a little bit. But again, supply changes. What does it do? Affects consumption-related harms. So one of the biggest ones are what we're calling nitazines. They're a weak mu receptor opioid with a benzene ring. They're kind of benzimidol opioids, and they've been appearing. They're designer. They're not approved for any use. There's no medical benefit of them, but they're slowly working their way into the drug supply. I've been scared of illicitly manufactured benzodiazepines for years. And in fact, the UK's overdose crisis, their fentanyl are illicit benzodiazepines. They're being mixed in with the heroin. And we all know what an opioid sedative or an opioid benzodiazepine mix does. For everything from hypotension, bradycardia, et cetera, and how the kappa receptor interacts with that mu receptor to really put people out when naloxone sometimes isn't as effective. We're starting to see illicit benzos come in. I've been telling FDA for the last 3 years, we're going to see this, and it never happens. And unfortunately, I'm right that it is slowly creeping in. And I'm going to show you some that's right here in North Carolina in our backyard. But the biggest one I think that's having the most harm, that's the most prevalent, is xylazine. There was a paper from Philadelphia. Xylazine first appeared really in Puerto Rico in the illicit drug supply and made its way into Philly. And this paper shows that it's been around since about 2008, 9, and 10. Really important paper, one of the first ones to drop. And then CDC came out with the notes from the field using their SUDORs surveillance system. I was at CDC when we developed that. It's a great system looking at not just opioid mortality, but non-fatal overdoses. And they're seeing xylazine, just a 1%, 1.5% of deaths, but increasing in about 36 states. And so FDA just came out with an alert as well, looking at xylazine, and they highlighted specific skin and soft tissue infections with it. And I'm going to highlight that in a minute. Also, the DEA, the growing threat of xylazine mixture with illicit drugs. Now, it says illicit drugs here, but I'm going to tell you what drugs specifically that they're being found in. And again, the xylazine panel will go into that in more detail. So what is the deal with xylazine? It's known colloquially as tranq, zombie drug. It's a really potent sedative. It's very strong. It's not an opioid. It's a alpha-2 androgenic receptor agonist, kind of analog of clonidine. Not approved for humans, very important. It was discovered in 1962 as an antihypertensive. Used currently as a veterinary anesthetic, and the recommended dose varies between species. What's important, though, is it was tested on humans early on, and it showed real high risk for hypotension, lowering of blood pressure, and bradycardia, lowering of heart rate. It was not approved for FDA. And so the mechanism of action in humans is relatively unknown. We don't know a lot about it. And I think that's why I'm really excited for Zoe's talk. I think she's been doing animal studies and trying to get to the notion of what does xylazine? How does it give respiratory depression? How does it work with the mu receptor? How is it a contraindication for overdose and related harm? And so let me make a shift there. So I took you through the drug market up to the supply and up to the change and what we can call the fourth modified wave or the fifth wave. This data that I'm going to show you is from a study I'm doing on fentanyl test strips. I'm working with Olive Branch Ministry in the Gastonia and Hickory area of North Carolina, partnering with Bill Zuhl, who's worked in Western North Carolina. It's a longitudinal mixed method study doing baseline 6 months and a year. with people who inject drugs and visit an SSP. The SSP delivers fentanyl test strips, offers them for their participants. And it was recruiting from the SSP. Our objective was to examine the individual and structural factors associated with FTS use. How are people using them? Why are they using them? And to investigate any changes in behavior or risk. There's actually no data on fentanyl test strips, right? And all these states are going in big time with money and buying them, but the evidence is a paucity of evidence, very, very thin. And so this will hopefully be one of the first studies to shed some light. Are people using them? What are they using them on? Do they even like them? Is it worth spending money? Et cetera. So we got 541 people. It was in 2 sites, West Virginia and North Carolina, 378 recruited, right down the street there in Gastonia and Hickory, and then 163 from West Virginia. This is really the area. We're in Catawba and Gaston County, but the SSP serves all these counties here. So this is really our feeder counties and the study reaches. And this is Bill Zuhl's county for the Rural Opioid Initiative, which was an NIH-funded study. There was about 7 sites around the country, all rural. The focus was on hepatitis C. And so the data we have for this whole area is really, really rich in terms of the drugs. And that's what I want to present here. And so I'm not presenting on fentanyl test strips, but we ask people what drugs they do, what drugs they inject, how they use them, right? Because we want to understand the different drugs people are using and how they're using them to understand fentanyl test strips. But I wanted to present the drugs because we're talking about drugs and this is local. I do believe what I'm about to tell you is the scene in North Carolina. It changes in urban areas with cocaine and different drugs, but in the rural western component from, let's say, the Piedmont West, this is definitely it. I talked to my colleagues in West Virginia and Kentucky. This study is also from West Virginia. Very similar dynamic in terms of the drugs that are available in more of the rural areas and how people are using them and what's happening. So if you look here, this is past 30-day use, just use, not by route of administration, just consumption. And if you look, methamphetamine's the highest, it's the highest in this area. And it hasn't always been the highest at needle exchange programs. That's very interesting. It's always been opioids. There's always been meth and coke, but it's always been driven by prescription opioids and heroin. And back in the day, before the opioid epidemic, it was mostly driven by heroin, some cocaine, but mostly opioids. But the rise in methamphetamine is really stark. And I showed you the rise in supply using the seizure data, a doubling of supply. And we know that. Heroin as well. Heroin is in North Carolina. Now you can't find any that doesn't have fentanyl in it, but I'm going to show you a picture of the heroin just to put a picture to it. And then heroin mixed with meth. So we know people are using those together. Benzodiazepine is really important. More people report benzos than fentanyl. Right? And then you can see the drugs as you go down. Really big increase in buprenorphine. There's also a slight increase in people injecting buprenorphine as well, which I'm going to talk about just briefly. And as you can see, stuff going down. Crack and cocaine are lower because, in rural areas, there's not a market for it. It's not that people don't like it, but the market is really circulated around urban areas. There's some that makes its way in, but it's very expensive. And the way people talk about it, it creates that Jones where you need more and more. Meth just lasts longer. You don't need it every 15 minutes. Although the meth is changing and people say that you need it more and more. And I want to talk about that in a sec too. So this is past 30-day injection. And if you see methamphetamine still at the top of the list, it's at the top of the list for every figure. And then you got heroin mixed with meth, fentanyl mixed with meth. So these are the main drugs that we're seeing. Heroin, fentanyl, and meth. And if you go to more urban or suburban, you put cocaine into that. So illicit opioids and illicit stimulants, that combination, but with some benzodiazepine thrown in, buprenorphine thrown in as well. But it's, you can see, very little pills. And I'm doing a study for the FDA right now on prescription opioid stimulants and opioids and stimulants, and we're finding very little pill use. So it's very hard to find pills. They're very expensive. It's really a middle class bourgeois thing now. Or someone knows somebody with a script and they wait and once a month they get 10, 12, 15 pills and they use them for a few days and that's it. So it's really working with the illicits as a kind of addendum or a compendium rather than actually the main drug. And these are just drugs smoked in the past 30. I just want to show this, methamphetamine topping the list. But here, fentanyl is increasingly being smoked, right? It says here, heroin is a difficult drug to smoke, but fentanyl is not. It's a very oily drug. And so when you light it, it turns to oil very quickly, like methamphetamine. And you can put it on a foil and chase the dragon with it. You light under the foil and the powder turns into oil and rolls down the foil and you can smoke it. This has been a huge, I'm saying huge, I'm not being hyperbolic, increase in fentanyl smoking. And I want to talk about what the implications are for that, for harm reduction and the supplies that we need to offer people. So these are just some pictures, okay? The heroin in Western North Carolina is referred to as activated and unactivated heroin. It's very interesting stuff. I really hadn't figured it out. I got to go to my kind of chemist colleagues to figure out what's going on. But they call it unactivated, but I think that's grammatically incorrect. I think it is inactivated, so I changed it for our audience here today. But they call it unactivated heroin, and it's in powdered form, and then when you breathe on it, it turns into tar. Literally, like you're like... I've seen it. I took this picture. So I've seen them do that and breathe on it and have it, and it doesn't go back. And we know that tar is not good for your veins. It causes a lot of tissue damage, arterial damage, kind of subcutaneous infections. And so there is heroin. Now, I've tested a lot of it with fentanyl test strips, and we sent it to UNC's Street Drug Analysis Lab and Dr. Dasgupta. Most of it has fentanyl in it. There is some that we found without fentanyl, but it's really few and far between. So heroin is a really important one. And then this is the fentanyl, and this is from Greensboro in the upper Piedmont there, and it's a kind of grayish light color. And it's, sometimes it's that white that we've seen, but very rarely is it white. It is, but it's been in this gray kind of color. And then this is fentanyl on the right and cocaine on the left. And as you can see, it has that kind of grayish look. And so the fentanyl varies, and there's so many different types of it. This is fentanyl sold as pink heroin about 4 years ago in the Greensboro area. And we found that it was fentanyl, acetylfentanyl, regular fentanyl, heroin, and something else in there as well. So the drug supply, in terms of the changing nature of the drug supply, how do you navigate a drug supply that's changing day to day? Like, how do you stay healthy and stay alive? Before harm reduction, we used to tell people and teach people how to use safely, how to inject safely, how to make your environment safely. More and more, that's difficult to do because it's not their behavior. It's the supply itself driving these crazy drugs that are having effects, whether you like them to or not. And xylazine is one of them. And I'm going to bring that up in a minute. So this is fentanyl under a black light. And so what's interesting about fentanyl smoking is when you light it on a foil, it turns different colors. And people, when they light it, they can tell the different types of fentanyl by the colors it changes. And it turns out this is under a black light. But if you don't use a black light, carfentanil turns green. I had 5 different people that didn't even talk to each other tell me that. And regular fentanyl turns blue. And that's how you know if you're getting stuff. If it turns black right away, it's garbage. This is under a black light. People say, oh, it turns green under a black light. This is how the fentanyl rolls on the foil. So, you put the fentanyl right there, you light it underneath, and you hold it at an angle, and the oil rolls down. And then you have a straw, and you chase the vapor as they come up. And that's chasing the dragon, because the vapor is the dragon. You get it. And so this is happening a lot. More and more people are smoking, and I'm really happy about it. If I could say that, I'm going to tell you why I am happy about it and people moving away from injecting. And this is methamphetamine. Methamphetamine is methamphetamine, but it's changing like crazy. The people that talk about methamphetamine from back in the day when it was Sudafed driven talk about it as changing big time. It's not the same. It doesn't do the same to me. I can sleep on it. I can eat on it. I can inject it 3 times a day. It's not doing the same. So we know that meth is changing as well, and in different ways. And so I want to do a nice little mini shift again. This is a qualitative study we did with people where we were asking them, hey, how did you find out that fentanyl was in the heroin in the beginning? And then what does fentanyl do to you? And what is it making you do in terms of using other drugs? And the findings were really interesting, and I think really important for understanding things. And so they were really good at detecting changes in their drugs. They could tell without there was something in it that was like turbocharged, and they welcomed it in the beginning. Fentanyl was relatively weak. Heroin was relatively weak, especially in rural areas when it's made its way from Charlotte up into the hills. It was stepped on so many times that people were like, man, this stuff sucks. We welcome a little bit of fentanyl as a turbocharge. And so they kind of understood it. They looked at it as chocolate chips, and they could see white specks in the brown, and they could tell the feelings and identify it. We even did a study if we're using a test strip, if they could, like a Pepsi versus Coke taste test, if you could test it and then test it with a test strip and see if it was heroin or fentanyl. And they could tell that it was fentanyl. And this is one of my arguments using or working with people who use drugs to figure out our sentinel surveillance. They're the ones who are interacting with drugs all the time. They have such a knowledge that can be useful to us. Again, blood and urine talks, very slow picking up new drugs. Law enforcement is not testing for xylazine, right? When it appears, right? And so who is engaging all the time? Where are those markers? Where are those signals in the noise going to come from? And from my research, it's consumers. Very interesting when they talk about the change in fentanyl. Fentanyl makes you nod out real bad. Regular heroin does that too, but the fentanyl is a lot stronger. Fentanyl hits you right away, but it doesn't last. It's got something that lasts more than 10 minutes. You found some really amazing shit. So it's way, way heavy, way sedative, and we know it is. That's its job in the medical system, right? It's given with propofol, so it literally knocks you out. The fentanyl is the thing that knocks you out, right? Then you give the propofol to stay out. Right? But the fentanyl knocks you out. That's why it knocks you out in the illicit world. It's the same thing. And it's literally knocking people out. People can't even get the needle out of their arm when they die. It's not like a slow descent into respiratory depression. People are dying quickly and they're going out quickly. And people are saying that it's so heavy, I can't get my head out of my lap. And it doesn't last. So if it doesn't last, what are you going to do? Now you're going to use it more. Now you're going to inject it more. Now people's injection frequency is going up because fentanyl only lasts 5 minutes. So now you're injecting, right? I've had people that are injecting 30 times a day, right? High injection frequency. And we know the more you inject, the more parental exposure, right? You have to infectious disease, overdose risk goes up, etc. And so again, how does the change from prescription opioids to heroin to fentanyl affect people and affect their use? So they're injecting more. And here's the kicker. Here's what I find is the most important stuff. These days, the meth I do is to counteract the fentanyl. And that's what we're seeing. So why are we seeing so many stimulants and opioid overdose deaths? Why are people using stimulants? Is it because there's a drive in supply and it's just available now? Partly, right? Is it because people are really digging the meth? Partly. But more importantly, it's because of fentanyl. Fentanyl is knocking people out and they can't stay awake. They can't drive a car. They can't do a forklift. They can't. It's like narcolepsy. When you talk to somebody and all of a sudden, and then they wake up. Can you imagine living your life like that, not knowing if you're going to fall asleep or not? How do you even function? When I interview people and I say, hey, what did you do when you did prescription opioids? And that's the first drug you did. What did it give you? Like, why did you chase it? Why was it so good? Everyone says the same thing. Nearly everybody. It gave me energy. It gave me energy. Right? People that use opioids don't want to be laid out, zombified and tranked. Right? They just want their vertebrae to be click, 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 so they're like a normal person. Right? And do stuff. Fentanyl's not allowing them to do that. We're doing a study right now looking how fentanyl is affecting worker productivity and employment. Because if you can't even stay awake, what does that even mean for labor and employment? We have a lot of jobs out there in the market. Our people have a hard time getting them for all sorts of reasons. Felonies, urine tests, etc. But the fentanyl, they can't get their head out of the lap. Now, put sedative in that mix. Put strong xylazine in that mix where you're already out. I was calling fentanyl a zombie drug way back when. Because it doesn't give you that euphoria. There's nothing to it. People aren't really liking it. It's a bad product. Let me just say this too. When we were looking at the fentanyl test strip study, the number of people out of the 541 that just did fentanyl, there was 3%. 3%. Just fentanyl. It was either all meth or fentanyl and meth. No one does just fentanyl. So is it that people like doing a lot of drugs, or is it the drug supply is changing and people are trying to cope with it and adapt to it? That's what kind of our research is showing. And so the meth, right? I still inject meth, but it's not the same as it was back in the day. It's sleepy. We call it sleepy meth around here. You know, the meth has changed over the last years. It used to be fire. 20 would keep you up for days. And then there's roach spray. People are making meth out of ant and roach spray. They're called waspers. It's just a real small percentage, but we're finding it. They take a screen and they spray the bug spray on it, and then they electrocute the screen with the cables, and it kind of turns the spray into crystals. And then you could sell the crystals. The crystals looks like shards. And we're seeing this more in rural areas, kind of with other effects on the methamphetamine. Mara Lieberman, who's a chemist, has looked at how the meth is changing and the relationship between D-isomers and L-isomers and their relationship. Are drug trafficking organizations using a chemical process to really change the meth so it's more of a D-isomer or more of an L-isomer? It's really strong, it's really pure, but it doesn't last. Blowing people's receptors out. They're just burnt out. They're sleepy. They call it sleepy fentanyl. They think it's meth, the fentanyl in the meth, but we haven't found a lot of fentanyl in the meth. Very little. So it's the meth itself. And so, you know, we also, how do we understand meth changing and the harms of meth in different areas? The law enforcement qualitative checking doesn't do that. So let's bring it back. Maybe I said the illicitly manufactured benzodiazepines. Well, here we go. Discovered in Hickory, right down the street. We found these pills. They were called green monsters. Nobody knew what they were. They thought they were morphine, heroin, and a benzo. The person I got this from swore it was a benzo. She didn't know. She ate it. She lost 3 days. Again, she said, I don't want to lose days. I'm not looking to be zonked. We do find people wanting to be zonked out with a lot of trauma. You know, people with a lot of trauma, it just helps, right? You don't want to be in your head. Moms that lost their kids, right? Veterans of war, people that are carrying trauma with them. We see that population, benefits from that, they say, but the majority don't. And they didn't even want this. This person gave this to me to send it to NAB to get tested. It was like, please take this. I do not want it. I don't even want to sell it to anybody. And it was clonazepam. It's a designer benzodiazepine. NAB doesn't have an origin for it, but it's absolutely a designer. And it looks like a Xanax bar, right? It's like a 2 milligram Xanny bar, so to speak. So that is here. We do have designer benzodiazepines here. We haven't found them in the drug supply yet. Not in any quantity that can have effects. And then xylazine is here. And this is the benefit of having a street drug analysis lab in your state. We sent heroin samples, fentanyl samples to them, and we found fentanyl, xylazine, and 4-ANPP as a precursor chemical to fentanyl. It's how you make one of the precursor chemicals. And so we have designers. So all those trends I showed you, they're in our backyard now. And I want to kind of close with this just push in terms of the health outcomes. And I know I'm going a little bit over, but I just want to take that time and I'll exploit it to go over this. I just want to raise a couple public health issues because we have the overdose crisis. We know we have a hepatitis C crisis. We have a developing HIV crisis. I didn't say this, but methamphetamine is leading to heightened sexual activity amongst people. When you work with people that use opioids, people generally don't have sex on opioids, especially when they get a habit and they're dependent. Methamphetamine changes that game. Speed is a libido enhancer, an aphrodisiac, right? Just anyone who does speed or amphetamines or MDMA. And so we're seeing heightened sexual activity. We're seeing increased sex work, but we're seeing heightened sexual activity. We're seeing increases in gonorrhea and syphilis, and those are usually markers for HIV increase as well. So increased meth, again, how is the market changing? Fentanyl driving meth. Oh, now people that didn't have a lot of sex are having a lot of sex. Oh, now we're going to have sex-related HIV risk with injection-related HIV risk. That's what happened in Scott County, Indiana. HIV got into that community through sex work. And we know patient zero in that. I was involved in that investigation. And the person contracted HIV and then brought it into Scott County and was injecting with her peers. And so sex-related HIV getting into the PWID population and then rapidly transmitting with people using together. So that's a big risk. So that's one. We got a huge risk in endocarditis and bacterial infections, and that's really been lost. And I just want to put that on our radar that I think the next health crisis at our door are wounds and our abscesses. And so lost among skyrocketing overdose deaths is an alarming burden of injection-related wounds and skin and soft tissue infections and invasive bacterial infections. So that bacteria getting to your heart, endocarditis or into your bone, osteomyelitis, requiring long hospital stays, expensive procedures, and oftentimes amputation and death. Abscesses have been a concern for, since the hypodermic syringe was invented in 1872. People have been, dealing with bacterial from parenteral exposure. But factors driving the recent ones are different. They're different wounds and they're also different conditions. In fact, the ONDCP, the Office of National Drug Control Policy, came out with their emerging threat analysis, and they listed xylazine as an emerging threat based on it's creating a novel illness. They called it novel clinical illness. And we read this as chronic wounds by suspected exposure to a drug. So a new wound typology even appears to be forming. So not just like regular abscess that we see, but a new typology. And how we're kind of seeing this new typology is traditional infections, right? They're usually from unhygienic infections, injecting a lot. They also from subcutaneous, like mist shots. You inject meth, you miss a vein, and you get that bump under the skin, and that turns into a knot, a cutaneous nodule, so to speak. Sometimes it can pop through the skin. Non-sterile injection equipment, unhygienic environments. We know that. But what we're seeing are novel wounds that aren't healing. They're having a really bad time healing. There seems like to be some venous insufficiency, some blocking, some venous pooling. And we're finding it's really related to illicit opioids and specifically fentanyl. And so we've been linking xylazine is the one constant that we're seeing related to these wounds. And so we've been calling them xylazine wounds or X wounds. They're characteristically different. The biggest thing is they're often non-infectious. They almost look like chemical burns in a way. And they're distal to the injection site, right? Abscesses are at or near the injection site, right? You're injecting, you get bacteria and it grows. It could get big. And so it looks like it's not, but it is. We're seeing these wounds in the lower extremities, like diabetic related wounds at the between the knee and the ankle, on the fingers and toes. Big article in the New York Times recently about amputations of fingers happening with that. I'm talking nasty stuff. It makes us think of crocodile in Eastern Europe, right? And we never have crocodile here because it's a codeine-based medication and desomorphine, and we don't sell codeine pills here. So it's never been a concern, but those type of burns and wounds we're seeing. And this is what they look like. So this is a traditional kind of abscess, right? Injecting in the vein and you get it and it's bad, but it's it's pussy, and it's hot. And then these are the cutaneous nodules. My target shooting would be way off, right? I can't even keep that straight, but that's a different thing. All right. So that's the copy. The cutaneous nodules from meth. And this is a person who injects meth. And as you can see, all the nodules, some of them pop through. So this is what I was calling type 1, type 2, and this is the xylazine type 3 wound. Way away from the injection site, really expansive, necrotizing quickly. It can turn black, really nasty stuff. And this is what we're seeing. Kneecaps, elbows, fingers, ankles. And sometimes they're so bad that you need to link people to care right away. You can't do them in situ on site. This is so much so that, needle exchange programs are leading the way again, right? Who leads the way on everything? It's always needle exchange people. It's always outreach workers. Us scientists just stay for the ride and just hope that something's invented that can save us all, right? It's like hoping that we can suck carbon out of the atmosphere at some point, right? So we're all content. All right, tech will fix us. I'm always thinking, consumers will fix us. They'll let us know what to do. So they put this out. I think it's Prevention Point Philly. I think I cited that. Oh, no, it's Van Asher, our harm reduction colleague who's now working in Chicago at Dan Biggs' old place. But this is what they were handing out. They were talking about supplies, how to deal with it, what are xylazine runes, red flags, helpful tips, right? The kind of black fasciitis, trank dope, calling what it is as a cunning agent. And just some stuff that we're seeing, which is really important. And I know I'm really close to going over. I'm going to close with these couple slides. What we're seeing is that it can totally knock you out for several hours. Not that fentanyl doesn't do that already, but we're seeing people really knocked out, unresponsive. We're seeing overdoses where people are unresponsive, but breathing. That's a big one. So you can't wake them up, but they're not in respiratory depression. So what do? You give naloxone. Sometimes that works. Sometimes it doesn't, reports we're getting. Naloxone usually works, but xylazine, alpha-2 agonist, slight at the mu receptor. Is it like an opioid sedative? What's it doing? What's the interaction? We don't know a lot of the mechanism of action. That's why the animal studies are so important. But NAB from this drug analysis lab says we're not going to just see xylazine. We're going to see other alpha-2s. Xylazine's an animal tranquilizer. They think it's coming just from veterinary clinics and because it's not a scheduled medication. So you can get it. You could do a slight chemical process on it and turn it into a powder and add it to fentanyl. So it's not in the meth. We're not finding any xylazine in the meth, not in the cocaine. It's all fentanyl. Now, consumers that are doing it are saying that it gives the fentanyl legs. Remember I had said how fentanyl doesn't last? They're saying that the sedative gives it legs, but again, it's sedative legs. And, our people want opioids, right? They're not doing an opioid to get its sedative legs. And so it's extending it, but it's not really their ideal. And again, no one wants to be knocked out. But NAB thinks that we're going to see more drugs. Again, how do we find out what these emerging drugs are before we wait for overdose mortality and medical examiners to figure it out? Or law enforcement takes a long time. They're inventing xylazine test strips right now. BTNX, who makes a version of the fentanyl test strip, has a xylazine test strip. They're just hitting the market now, but my colleagues tell me that the chemistry in it is a little dubious. And so there's a lot of nuance to it. And it's not the same mechanism as using a fentanyl test strip. So that will be a little complicated. And like I said, we know it's complicating treatment with overdoses. Also, methadone and bupe don't stop withdrawal. You can have a xylazine withdrawal, right? Because we know sedatives are physically dependent drugs. All the depressants are physically dependent and all the stimulants aren't. That's just the way it is, right? Benzodiazepine, use those for a couple months. Good luck getting off those, right? Opioids, alcohol, barbiturates, and I'll also include the neurotransmission drugs, right? Gabapentin and Lyrica. Let me tell you, you talk to people that have been taking Lyrica and gabapentin for your months, tell them to get off that drug. Tell them to stop taking it. See what happens. A very physically dependent drug. We don't talk about gabapentin enough, and it's beyond the scope of my talk here, but it's really flooded in the market right now. And it has contraindications with opioids. It acts like a sedative. It's an effect modifier for sure. But what's happening is we have people with a sedative. Now, if you're treating people for addiction, right, they come into your clinic and now you're like, oh, I have an opioid use disorder. Oh, we have a drug for that. We have a couple different options, right? Oh, now you're finding out that they have a stimulant use disorder because they've been using meth, right? Because of the fentanyl. Now they have 2 disorders. Oh, now I'm gonna have maybe xylazine, unwittingly even taking it. So you're treating my withdrawal for opioids, but now I'm withdrawing off a sedative. And how do we deal with that, right? So now we're talking about benzodiazepine disorder, stimulant disorder, opioid disorder. So what is the change in the drug supply and all the shite in the drug supply, for lack of a better words? What does that affect on treatment, right? How do we treat people with multiple disorders and contraindications? And so I think it's important for us to kind of do a deep dive in what people are using and testing their stuff. Because a lot of times people are using stuff unwittingly. They don't know what they're taking. They go into treatment, they're given a urine test or a deep test, and they're like, oh, you have benzodiazepines in your system. And they're like, no, I don't. I really don't. And they really believe they don't, but they do because there's stuff over. And so there's a lot of good literature out there on xylazine overdoses, what's happening, what we can do. And so I want to close with asking this question, what do we do in response if the drug supply is the origin of the problem? Harm reduction is based on 2 things: impacting behavior and impacting the environment. That's all we can do. We don't mess with the drug supply. We haven't had to worry it. Fentanyl, we're worrying because it's an overdose and there's other stuff with it, right? And that's why it's killing so many people, but that's the drug supply. You can be the best, most responsible consumer in the world. Fentanyl can still kill you, right? It's that Russian roulette aspect you don't really know. So the drug supply, but if we can't mediate behavior and we can't mediate environment, what do? What does it mean for harm reduction? How do we modify harm reduction? And so I want to close by saying we really need to expand testing. We need to treat this epidemic like a food-based pathogen epidemic. That we have a pathogen in the food supply. We need to test what it is, where it is, and respond. We need to test the lettuce, in other words. And we're not doing that. I'm using law enforcement data retrospectively. If I can prove retrospectively and forecast overdose mortality that already happened, we can do it prospectively. And we can start testing in our neighborhoods and finding out risk factors geographically. What neighborhoods have what drugs? How do we respond? We have to do that because there's no other way. If you're hooked on fentanyl, you're getting xylazine. You're going to get a wound whether you like it or not. If you're using regularly, how do you prevent that? You can't use that safely, right? It's just over time. So it's really kind of changing what we're doing as a people in response to this. And I just want to put a charge out for community-based drug checking is what we're calling it. So we work with the Street Drug Analysis Lab. We're doing point-of-use fentanyl test strips. And the slide before is a little FTIR machine that you can put at a needle exchange, at a community-based organization and start testing locally what's happening. And so I think thinking about how do we respond to this as a supply side issue, public health, not law enforcement supply side, public health. It's new for us. We're not used to that. We need to figure it out because the supply is really what's having its effect. Thanks for letting me go over. I'm really sorry about that. And thanks for listening.